Welcome to AETCM, the emergency medicine channel. Presenting the case of a 25-year-old male who came to ER with complaints of fresh bleeding per rectum with pain around the perineal region, which occurred 2 episodes since the last 12 hours. On initial 10-second assessment, the patient was conscious oriented. He was talking in full complete sentences. The airway was patent. There was no pooling of any secretions or gurgling sounds or stridor. On breathing, the saturation was 99% in room air. The chest was clear and respiratory rate of 18 per minute. With a circulation, the BP was 126/82 millimeters of mercury with a capillary refill time of 2 seconds and a heart rate of 80 per minute. The GCS was E4, V5, M6. The pupils were bilaterally equally unreactive to light with a size of 2 millimeters, and GRBS was 96 milligram per deciliter. And exposure-wise, the temperature was 98.1 degree Fahrenheit. There was no presence of any rashes or external injuries, or ecchymosis was not present. We assessed the pain score. The pain score of the patient was 5 out of 10. So initially we had given an injection, paracetamol 1 gram IV stat was given for this patient. Following which the pain score had reduced to 3 out of 10. And as adjuncts to the primary survey, we had taken a CBCRP point of care was taken for this patient, showing a hemoglobin of 15.4 with a hematocrit of 46 and a platelet count of 186,000 and CRP of 0.7. And the patient also was taken a VBG, which showed no acidosis or alkalosis, and the HB was 15.3 with a potassium of 4.2, sodium of 138, and creatinine of 0.6 and lactate of 2.8. Following which we asked the sample history of the patient. The patient was a 25-year-old male. He was a known case of severe hemophilia A. He came to A. Yes. And he came to ER with complaints of painful fresh bleeding per rectum.
What are the types of hemophilia?
Hemophilia A and hemophilia B. So hemophilia A is usually the factor 8 deficiency.
C?
Hemophilia C is also there. Yeah.
A is 8.
8.
B is
9.
C is
11. Yeah. So this patient had a severe hemophilia A. He was on factor 8 supplementation treatment.
male or female?
Male, yes.
Male patients develop hemophilia or female? Which is more?
Male is more.
Male
Females,
predominant disease. Female will be
carriers. Yes. So he's a 25-year-old male. He's actually known as of severe hemophilia A who came to ER with complaints of painful fresh bleeding per rectum, which occurred 2 episodes. Each episode had a quantity of about 100 ml with clots. And
but his HP is normal.
Yes.
Why you think it is like that? What is the reason?
This patient had a hemo concentration.
So he may even get a normal hemoglobin level and high hematocrit.
Yes.
Slowly it drops.
Yes. Following which the patient also complains of a regional pain along the anal orifice region, and the pain increases while he's straining during passing his stools, and he's complaining of difficulty to the pass stools also. And he's no history of any melena or hematemesis, or no history of any oral bleed, no history of any blood in urine, no history of any hematuria, or no history of any swelling of the joints or any ecchymosis around the skin. No history of any blurring of vision or headache or weakness of limbs or vomiting or seizure.
We are asking all these
because
seizure.
Yeah, so all these hemophilia patients, they have a high propensity to have a intracranial bleed also. So we just wanted to rule out the intracranial bleed. So we asked the history regarding that.
Acquired hemophilia?
Acquired hemophilia, there is a presence of autoantibodies against factor 8. So in such patients,
the other one is a genetical defect. Antibody mediated. Afterwards, it occurs afterwards.
Yes. And so this patient did not complain of any breathing difficulty, no history of any trauma to the chest or abdomen. And
breathing difficulty history.
So we can rule out any presence of any hemothorax or hemotasis underlying. And allergic history, he did not have any allergic history. The medication history, he was on recombinant factor 8. He was daily taking it. And past history is a known case of severe hemophilia A. And last meal was taken 6 hours back. On examination, the patient was conscious oriented. Per abdomen was soft, non-tender. The bowel sounds was present. There was no presence of any external rashes or ecchymosis along the abdomen. And the CVS, the S1, S2 was normal. There was no presence of any murmurs. There was no presence of any pedal edema. And CNS, there was no presence of any focal neurological deficit for this patient. And the chest was clear, the air was bilaterally equal. There was no presence of any added sounds. We also did a perectal examination. In the perectal examination, there was presence of an anal fissure for this patient. There was no presence of any hemorrhoids was not present. With blood staining was present. With clots was also present for this patient. So initially itself, the patient to reduce the bleed, we had initially given an injection, tranexamic acid. We had given 1 gram. IV stat was given, and following which we had also arranged blood for this patient. But more than that, we have also arranged for factor 8 for this patient, because this patient is already taking factor 8.
Factor 8 is not available. What you do?
We can go for prothrombin PCC or
normal hospital. It will not be available. You can give FFP.
FFPs.
There is no other choice. FFP, cryoprecipitate, whatever is available, you can give. But ideal thing is factor 8.
Yes.
Okay.
Yes.
Tranexamic acid also may not work. Okay.
Yes. And following which we had given an expert opinion to the hematologist, and also the patient, since he has a fissure in rectum. Anal fissure, so we had informed the general surgery consult also for this patient. Following which we asked for the various things prior to the factor 8 transfusion. We initially asked...
What is the percentage of factor 8 in this patient?
This patient had a factor 8 less than 1%.
That means?
So he's having severe hemophilia.
Less than 2% is severe?
Yes.
Okay.
Yeah, so...
how it is graded?
It is graded as mild, moderate, and severe. So, usually in mild hemophilias, there will be present the factor 8 is usually in the amount of 0.05 to 0.4 interaction unit per ml. That is 5% to 40% of the 40% of the normal limit. So, if it's less than 50% of the normal limit, the factor 8, it is classified as hemophilia. So, if it's between 5% to 40%, it is mild hemophilia. If it's moderate hemophilia, is between 1% to 5% of the normal factor 8 level. And severe hemophilia is if it is the amount of factor 8 is less than 0.01 international unit per ml. So that is less than 1%.
What investigation other than factor levels will tell you that there is a factor deficiency?
We can do the APTT and PT.
Okay, APTT.
APTT is
okay. Yes. Tell me something about mixing study. What is mixing study? So this patient, you know that it is a hemophilia, so you don't have any doubt. You ask for APTT, it is elevated, factor deficiency is there. You correct it.
Yes.
But there are some patients, APTT alone will be elevated.
Okay.
Like antibody mediated disorder, you have seen. SLE and all, you can get it like that. Acquired hemophilias. How do you know that? What is mixing study? We are presenting a case of hemophilia. You should know about mixing study. We do it here. Because many patients, APTT alone will be elevated. You mix with the normal plasma of some other patient. I am only telling the process. It may not be like this.
Okay.
So that if it is antibody mediated, if you mix it normal plasma, this will be corrected. Other one will not be corrected because it's an antibody mediated. Antibodies are still there.
Okay.
So mixing study will help you to differentiate between your like congenital disease like this or an acquired disease which is induced by antibody. So mixing study has to be done when you are treating the patient first time.
Okay.
Here we don't have any doubt because it's a known case of the
severe hemophilia.
Okay.
Yes. So, as a part of a discussion of hemophilia, so hemophilia is usually there are 3 types of hemophilia: hemophilia A, hemophilia B, and hemophilia C. So, hemophilia A is usually the factor. Hemophilia A and B both are X-linked disorder. So, in this, it will mainly affect males, and females act as carriers. So there is the presence of the gene for this factor 8 and 9 is present in the long arm of X chromosome. So it is due to the deficiency of this gene, so there will be presence of factor 8 deficiency or factor 9 deficiency. Factor 8 deficiency leads to hemophilia A, factor 9 deficiency leads to hemophilia B. So usually as initial part of resuscitation in the ER, we should, in a bleeding hemophilia patients, we must ask a few important steps to resuscitation is there. Initially is the hemorrhage control for this patient, for arrangement of FFPs and factor and blood arrangement, and also giving tranexamic acid can help.
You give more blood. Unfortunately,
yeah.
what will happen to this patient?
So in severe bleeding,
the normal problem is when the patient is bleeding, either in trauma or hemophilia, normal tendency is to give more blood.
Yes.
So what will happen?
This patient can again go.
In trauma, it is especially in trauma. Somebody is bleeding. If you are giving only blood, what will happen?
The coagulation will again.
You might have learned about massive transfusion protocol.
Yes,
what
yes.
is that? So why we are giving like that 1:1:1? Why we are giving like that?
There will be dilution of the coagulation of the coagulation.
So dilutional coagulopathy, there is an entity. You give only blood, and whatever coagulation factors are there, that will still further dilute.
Yes.
Okay, so there is a high tendency of bleeding.
Yes.
So never try to give more blood in a patient bleeding like this. Okay.
Yeah.
If it is absolute emergency, only you give blood.
Yes.
Otherwise, you can wait. You can only correct the coagulation factors, or if you want to give blood, then always give with FFP and platelets. Otherwise, that also will be diluted.
So initially, as part of initial resuscitation and hemorrhage control must be done for this patient. Then we must assess the patient's history. So whether we should ask whether the patient is taking factor 8 at home, and also the person whether he is using a presence of inhibitors. If patient is on any factor 8 inhibitors, like is already known case of factor 8 inhibitors, and then we must also give an anti-factor 8 that medication is also there. Okay, so then we give the factor replacement therapy, but this replacement therapy before moving for an invasive procedure like an arterial line or a central line, any venous catheterizations, we must always ensure that we give the initial factor replacement and then only proceed for these procedures. And even in imaging, if patient we are suspecting an intracranial bleed, before going to the CT imaging itself, we must give the factor 8 as supplementation before going to neuroimaging. And the pain treatment, usually we should give only acetaminophen or opioids can be used, and aspirin or NSAIDs are contraindicated. And so then we must always ask for the expert consultation from the hematologist in this patient.
If this patient develops myocardial infarction, will you continue aspirin? So the common things will occur in practice. This patient after many years, 50, 60 years, he may develop myocardial infarction. So what do you do?
Thrombolysis.
Huh? Thrombolysis anyway you cannot try. We have to try for something. I am asking whether we can give antiplatelets
or not.
Huh? Yes or no?
No.
What is the mechanism here? What is the mechanism in antiplatelet? Both are different.
Yes.
Platelets are normal.
Yeah.
Antiplatelet has to be given. Here the problem is bleeding tendency.
Yes.
They are not the platelet defect. Okay. So in that case you have to give. You will come across this type of patients when they become old. When they become old, they definitely develop myocardial infarction or some ischemic heart disease or something like that. You will have to give antiplatelets.
Yes.
Okay.
So usually the pattern of bleeding in hemophilia patients, they will have a easy bruising. If the patient is having an easy bruising, gingival bleeding or any presence of hematuria.
The common presentation of these patients, young children to emergency room, hemophilia.
So hemophilia, they will be presenting
hemarthrosis. They fall down. Yes. Children, they fall down. Hemarthrosis is the most common presentation of this type of patients.
Yes. So if the patient is
Muscle bleeding.
yes.
Okay.
So, and the hemothrombosis, and even in severe cases like trauma, retroperitoneal bleed can also present in some blood trauma. And usually the psoas muscle hematomas are usually common in case of retroperitoneal bleed.
If patient develops hematoma, should we drain it?
Yes, in these patients.
Yes, sir.
Yeah, yes. Before that, we must give the factor 8.
Okay. We must give factor 8. Then only we should try it.
Yes.
Should we drain or not? Any muscle hematomas, should we drain or not? Huh? No need. Why?
Related to compartmentalization.
Blood is a
source for infection.
source for
infection.
That is the thing. Definitely, they will develop muscle infection in that area. There will be slowly it will become a collection of pus. Okay. So any large bleed into the muscle joint should be drained. Okay, especially when the patient is having immunocompromisation, diabetes, old age. Okay.
Yes. As mentioned before, the genes of the factor 8 and 9 are in the long arm chromosome X. The bleeding manifestations are usually directly attributable to the plasma activity levels of factor 8 and 9, and usually the patients with hemophilia, we diagnose initially by the presence of the hemostatic marker testing like PT and APTT. So APTT will be raised for such patients. So that is the initial investigation. Then following which, if the in hemophilia patients, usually the PT, which is the pathway of extrinsic coagulation pathway, it will be usually normal. But in APTT, the intrinsic coagulation pathway, it will be prolonged. So that is usually the features in hemophilia patients.
APTT is prolonged, PT is normal.
Yes.
Where else APTT is prolonged?
In von Willebrand disease.
Von Willebrand disease. Then which drug we are monitoring APTT?
Heparin.
Which bite we are monitoring APTT?
Viper bite.
Viper bite. First APTT elevates, then PT also elevates in that.
Yes. So usually then the factor 8 levels is what we check. If the factor 8 levels is less than 50%, that is less than 0.3 to 0.4 ml. So in such patients also they will be having hemophilia. And the bleeding.
Here mixing study comes. When you get an elevated APTT, you have to always check the mixing study to confirm that it is due to hemophilia or antibody mediated destruction. And
as a part of treatment, in case of bleeding cases of hemophilia, the treatment of bleeding initially involves the early replacement of the missing factor. So that is in cases of mild factor 8 deficiency, we can even try to stimulate the body to create factor 8. That is usually done by desmopressin. So desmopressin is what we use to increase the factor 8 levels. So the factor 8, usually the therapy, initially it involves, there are different sources for factor 8. So factor 8 can be even taken from a human plasma, or by the recombinant technology therapy can also be used to take the factor 8 samples. In hemophilia A, it also depends on the dosing regimen usually. It depends on the patient's volume of distribution of the patient, the weight of the patient, and also the severity of the hemophilia. So if the patient is having a moderate or a severe hemophilia, factor 8 replacement is the initial line of management. If patient is having mild hemophilia, before giving the factor 8 replacement, we can also try to increase the factor 8 production by giving desmopressin. So that is the line of management in hemophilia. So in hemophilia A, usually we should give this factor 8 is usually given at a dose of factor 8 is coming in a vial. So it is like between a volume of 250 to 400 international units per vial is usually present, and according to the body weight we calculate and we administer in these patients. So the administration of the dosage of administration also depends on the mechanism of the injury. So how severe is the injury, so that also it is divided. In case of minor in skin deep lacerations, we do not require a factor replacement. It's not required even in moderate to severe hemophilia also, because in such patients the platelets will be normal. So the patients can gradually by itself the bleed can stop in lacerations. So for such patients, we give a treatment with pressure and pressure management, and also we can give topical thrombin.
Okay.
So these are the both treatments in cases of cuts, lacerations. In minor manifestations, like in early hemarthrosis or in mild muscle bleed, or in mild oral bleed, usually the desired factor level for the patient should be between 0.2 international unit to 0.4 international unit per ml. That is between 20 to 40%. So in such patients, in hemophilia A, we give a factor 8 of 10 to 20 units per kg. And in hemophilia B, we give 20 to 30 international units per kg. So that's the dosage of factor 8 and factor 9, which we give in case of such situations. And we should give repeat doses every 12 to 24 hours, and up to a maximum days of 1 to 3 days of the bleeding. Okay. And in case of moderate manifestations, like if patient is having a definitive hemarthrosis, or a patient is having moderate muscle bleed and a moderate oral bleed, so in such patients the desired factor level also must be increased. So it's between 0.3 to 0.6 international per level. That is between 30 to 60% of the normal factor rate level. To achieve that, the factor 8 in hemophilia A must be given at a dose of 15 to 30 international units per kg, and the factor 9 in hemophilia B, we should give 25 to 50 international units per kg, and repeat dose is given every 8 to 24 hours, and until the bleeding subsides. So that is the case of like moderate hemarthrosis. In major bleeding manifestations, like a retropharyngeal bleed, which requires airway management, because the airway will get compromised, requires intubation for such patients, and in intra-abdominal GI bleed, and also in intrathoracic or in retroperitoneal bleed. In such situations, the desired factor level also rises. It's between 0.6 to 1 unit per ml. So that's between 60% to 100% of the factor 8 level must be present in the body. So for such patients, the factor 8 initially must be of 30 to 50 international units per kg, and the factor 9 which we administer must be between 30 to 50 international units per kg, and it is also given every 8 to 24 hours till the bleeding resolves. And in case
that
of
is not available, factor is not available,
we can go for FFP.
FFP is the only source then.
Yes. In cases of any CNS bleed, the desired factor level is always 1 unit per ml, so that 100% of the factor 8 levels should always be present. So for such patients, we should always give a 50 units per kg for factor 8, and 50 to 100 units per kg for factor 9. And early CT is also required for such patients. So these are the usual treatment in case of moderate and severe hemophilia. And in mild hemophilia, usually the treatment with desmopressin is used. So it is the mechanism of action of desmopressin is usually it increases the release of von Willebrand factor, so which increases the factor 8 production in the plasma. So that is the mechanism of action. We have both IV and intranasal desmopressin, and in less than 2 years, both IV and nasal desmopressin is not used. In less than 50 kg body weight, if the patient is having a weight less than 50 kg in more than 2 years, the dosage of IV desmopressin is between 0.3 microgram per kilogram. It's given IV over 30 minutes. And nasal, if you are giving desmopressin, it is usually a single spray on one nostril. It is usually given at 150 microgram one nostril. And in cases of, if the weight is more than 50 kg for the patient, we give IV desmopressin of 0.3 microgram per kg itself over 30 minutes, but we can give a maximum dose up to 20 microgram. But in nasal desmopressin, we should give one spray each nostril. So 150 microgram each nostril, so 300 microgram can be given through by nasal desmopressin. And in case of hematuria, If patient presents with hematuria, it's rest and hydration is the initial treatment. But if patient has a gross hematuria, factor VIII transfusion must be necessary. And so these are the different modalities of treatment. And in cases of factor VIII inhibitors will be present in some hemophilia patients. So they will be already having an auto antibody also present in such patients. So always in history we should ask whether patient is having any history of like factor VIII inhibitors. So in such
history they will not give. No, that's why mixing study is very important.
Yes.
Mixing study, this will not be corrected.
Yes. So usually 30% of severe hemophilia A patients and even 5% in severe hemophilia B patients, they usually have an underlying factor VIII inhibitors also. So in such patients, more than factor, like along with factor VIII replacement, we should also give anti-inhibitor coagulation complex. It is derived from the human plasma containing factor 2, 9, 10 and factor 7. So this complex concentrate must be given as part of initial resuscitation, and even we can give a recombinant coagulation factor 7A. So these are the modalities of treatment for such patients.
Okay. Anything? Nothing. Okay.
Yes.
Thank you.